Okay? What are the adductors going to help to do? Pull it down. Okay? So that's essentially what we're doing. We're kind of like gapping the SI joint, and then we're going to pull the pubic shear down. And we're going to do this technique bilaterally, so if one is up, it's going to get pulled back down. On some of you guys, when you do this to each other, you might hear a pop, and that's always cool when that happens. It's like so cool. It's like, because the patient's like, wow. So you guys may get a pop. Don't freak out. It's not a big deal. But you know you've probably done something. Yeah, the point of this is to fix a pubic shear that you may or may not have identified via palpation. So again, your choice is to palpate, and if they don't have it, you don't correct it, or just go ahead and do the technique anyway. What you're doing here is they're supine, their feet are close together. Bring your legs together. Your feet together, rather. Yep, there you go. I'm going to get my arm wedged in here. You can bring your feet a little apart if you don't have. There we go. Okay, so I could do it like this with my hands, or I could do it this way. I'm going to ask him to squeeze his legs together. This is the one exception. Before I told you all the muscle energy techniques are pretty sub-maximal. This is the one where we are using a maximal force contraction. So he's going to give a maximal contraction. You're going to bring your legs together and squeeze. So squeeze my hands. Bring your knees together. Really hard, really hard, really hard, really hard. Harder, 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 harder. So it's about 5-6 seconds. Okay, he relaxes. You're fine. Then what I'm going to do here is I bring his legs together, and I'm going to hold his legs. He's going to try to resist abduction. Now try to push your legs outward. Yep, and I resist. Okay? Good. 5-6 seconds. I relax. We repeat again. You'll feel the pop when they adduct. Come here, bring your legs out again. Yep, and squeeze. Real tight. Real tight, real tight, real tight. Okay.
You feel like that wants to go? I don't know.
Something's going on. Now relax. Okay, so either I have my hand wedged here and he's pulling together, or his knees are together and I'm just kind of hugging them and asking him to push his legs apart. If you're really strong, you can do this and put your hands like this and say push your legs outward. This is a harder workout for you guys, but you could do that too. Either way is okay. But it's just a series of pulling in, pushing out. That's the shotgun technique. Again, there's a few different ways to do this. This one we're going to show you is supine. You want to basically, so which one do you want me to treat? I'll treat the right side.
Right.
I'll show you how to treat it on the right side. You want to bring the right leg outside, so you're abducting it a little bit. I'm putting his leg or his foot against my thigh, okay? And what I'm going to do here is, this technique requires a lot of communication between you and the patient, okay? This is what I will say to them. Okay, Jess, what we're going to do is a technique where I'm going to be pulling on your right leg. And what I'm going to ask you to do is you're going to take a deep breath in, and then I'll say breath out. When you exhale, I'm going to just pull a little bit on your leg. We're going to do that about 3 times. On the 3rd time, when you exhale, I want you to cough, okay? But have you cough, and when you cough, I'm going to give you a little extra tug, okay? That's really all we're doing. The communication part up front, I think, is very important, because what we're trying to do is get the timing of the cough to be the same as the timing of your tug, all right? Essentially what happens is when he coughs, it drives the sacrum upward, and so I want the sacrum to be going up while I'm pulling the leg down to pull that innominate downward. So he's in slight abduction, slight internal rotation to kind of close back the hip joint. Go ahead and take a nice deep breath in. What's that? As you exhale, I want you to give me a cough, but not right now, okay? And you can hold on to the table if you want, okay? All right, so go ahead and just take a nice deep breath in. He inhales, he exhales, okay? I'm pulling. Go ahead and inhale and exhale. I'm pulling a little bit more. Go ahead and inhale and give me a little cough on the exhalation. Okay? So when he coughed, I'm just doing a little like that. I'm not doing this whole pulling him off the table sort of a thing, but it is a high thrust. It really is a high velocity. I don't know if it's a manipulation per se, because you certainly won't hear any cavitation with this, but it is a high velocity maneuver. Okay? So low amplitude, high velocity. So there, I'll just show you on this side to even it out. Okay? So right is posterior. What do I want to do to the right? She either has a left posterior or a right anterior, right? Right. So what I'm going to do is this. Scoot off the table. I'm going to let her right hip go into extension. I'm going to bring the left leg up and let your right leg start to hang down. Now, I let her right leg hang down. That's the posteriorly rotated side. I flex this knee up until I see the right hip start to come up, or the right thigh start to come up off the hip. So I don't go way up here, okay? I go right to about here. That's my first barrier, okay? So when that right leg pops up, that's my first barrier. Then what I do is I kind of turn my back to the patient, and I do this. I put my arm here, and I put my other hand on her thigh. And I ask the patient, push your legs toward each other. Okay, so gently push your legs toward each other. So she's basically pushing down with the left, and she's pushing up with the right. This is all isometric. So that's perfect, Terry. She does this for 6 seconds, and then she relaxes. And now I just go to the next barrier. So now I bring up, I don't have to push down on the right. I can just come forward on the left. I come forward, and I do the same thing again. So she pushes up on the right, she pushes down, push your legs toward each other. That tends to be the best verbal command. It tends to work. If I said push down with your left leg and up with your right, patients, for some reason, it's surprising if you said push your legs together. It's surprising to me that works so well, but it does, because I don't know that I could follow it. I would say pushing your legs together means adducting, but relax, okay? And then I'll bring you up a little bit more, okay? And then go ahead and push down again. And I could be hanging out like this, too. Depends on the size of your patient. But you're basically using your body to kind of keep them in their hip into flexion. And then she relaxes, and then I can do one more for good luck. Yep, go for it. Good. And then we relax. And then obviously you bring them back on the table, and then you reassess. When you reassess your patient, though, because everybody's going to always look better if you just put them right on the table and you check them. What you really need to do is reset their hips. So bend your knees, lift up your butt, come back down, and check everything like that again. Because otherwise you're going to just create this bias. They're going to just be positioned that way. So to really honestly check your work, reposition their pelvis and then recheck. And you cross your fingers and you hope that it works. Now these can be really stubborn. Innominate rotations can be really stubborn. Posterior innominate rotation is common. It's not uncommon, but the question is why is it so stubborn? It can be for a lot of reasons. If you've got the patient that just fell while snowboarding one time, that's easier to fix than the person that fell 2 years ago, or they had a hamstring injury 2 years ago and now their pelvis is off. The more chronic they are, the longer they take to get better. So the acute ones tend to get better. It's almost like the worse they are off initially, the better the response is initially. But again, if it's a stubborn innominate rotation, you've got to look at a lot of factors. Are they rotating because they're compensating for a longer leg? Are they rotated because they have a leg length different, a muscle length difference? Do they have instability on one side? I mean, do they have weak hip up? I mean, there's a lot of things you have to do with this fishing expedition. If you've got an innominate rotation that doesn't get better, you've got to just look at all other factors. Okay, what else could be contributing to this? If I have a patient with a long leg on the right, okay, how might the pelvis compensate for a long leg on the right? It will rotate it posteriorly, right? So something to kind of keep in mind with that. These can be really mind-boggling. You just hope that they work, but if they don't, you have to kind of figure out why is this not working, okay?